Hello, and my name is Dr. Michael Brazil. My specialty area is neurology. I practiced for 13 years and have always enjoyed teaching students, interns, and residents during that time. I, of course, trained med students, interns, and residents during my residency. I also had a private practice for 5 years and practiced in the Air Force Medical Corps for 4 years. And I've had a handful of externs, interns, and residents that would be present with me every day and would teach during my clinic hours and during rounds in the hospitals. I also have recently taught high school science, including anatomy, biology, and others. And that was for 4 years. And then I taught anatomy as a professor at State College of Florida as well. I'm interested in teaching for Kaplan so I can continue teaching by helping medical students better understand neurology and other topics. My availability during the year is wide open, and I will teach with Kaplan full-time if there's enough work, and I'm available to start immediately. I have experience preparing students for board exams during my practice time, and this year I have been tutoring medical students for another company, but I would like to transition to Kaplan instead. I also do medical consulting for a global consulting firm, and I may do that in between depending on how much work I can get from you at Kaplan. I will focus on Kaplan if you have the work for me. I appreciate this opportunity to speak with you and look forward to working with you soon. Okay, so I've chosen to do a topic on migraine here today. And so I put together a PowerPoint with some information. It's a huge topic, and honestly, I've done lectures for an hour before when I did dinner lectures for other physicians when I was practicing. So this is a very abbreviated version. And then the outline I'm going to follow here today is definition and criteria, some of the causes, the associated symptoms, evaluation, warning signs, treatment, and counseling. Headache or cephalgia is a very complex syndrome, and migraine is a subtype of headache. This is a copy of a migraine book by Oliver Sacks, which is excellent if anyone wants to get really in depth about migraine. This is just some more information about Dr. Sacks' books and movies that were made from his books. The definition of migraine is listed out here, and it's a familiar recurrent syndrome characterized by usually unilateral pain, accompanied various focal disturbances of the nervous system, particularly in regard to visual phenomenon, such as scintillating scintillas. And then there's different types of classifications that can be explored in depth in the future. And this cartoon here shows about migraines, the basic characteristics that I just discussed: unilateral, 2 to 72 hours, sensitivity to light, sound, or smell, pulsating, nausea, vomiting, and symptoms worsened by physical activity. Criteria for migraine, as was in the previous slide, again, unilateral, throbbing, interrupts daily function, recurrent, and often familial. There are two types of migraine, and there is one with aura and one without. More common, all migraines are in women than men, and it runs in families. And 85% of cases are without aura, preceded by fatigue and difficulty concentrating or thinking, and often other symptoms. And again, here's just the outline, and so we're going to move on to the other items on the list, causes and associated symptoms. So the etiology of migraine has been very difficult for the last 20 years. We have more information now, and it's primarily thought of as a trigeminal vascular activation through the trigeminal nerve, and developing with cortical spreading depression across the cortex from the occipital to the frontal, There's a role with serotonin, obviously, that's implicated with the treatments. There is sensitization items as well as genetics involved. Okay, so cortical spreading depression. You can see, I apologize for the video covering up part of this, but it starts in the occipital and progresses forward over 20 to 30 minutes. The activation starts here in the trigeminal nuclear center in the pons of the midbrain, pons and midbrain, goes up through the thalamus and hypothalamus, goes to the cortex. Here's another illustration of that previous slide. In this one, again, you got the central area here in the trigeminal nucleus and the pons, going up through the hypothalamus and the thalamus. Those two are important to remember for board questions. And then going up and getting the cortical spreading depression from occipital to anterior. The pathophysiology is much better understood than it first was in the 90s, mid-90s, when I was a new resident, and Imitrex was the first triptan medication that came out in 94, I believe. And so we understand a lot more with the pathophysiology at this time. And this kind of shows the cranial nerve 5 and neuropeptide release of VIP, substance P, CGRP. And you can get activation of nociceptors for sensory symptoms, mast cell degranulation, extravasation of plasma protein, and then you get vasodilation. Some notable triggers for migraine include food, stress, aromas, hormonal changes, especially estrogen surges, dehydration, poor sleep, and sedentary lifestyle. Migraine triggers, as discussed in the last slide, increased stress, I've always seen in practice, is the biggest one, but the others definitely play a role. Sleep pattern changes, fluctuation of estrogen during menstrual periods, MSG, aged cheese, chocolates are triggers. Associated symptoms of sensory aura, prodome, light sensitivity and noise, nausea, vomiting, fatigue are some of the associated symptoms that are frequently seen. Here's an illustration of some visual auras with the scintillating scotomas, the geometric shapes, and sometimes altered vision in the center part here. And then I apologize, in the future, if I'm recording these with video attached, I will adjust the slides. But this is a graph here showing from 0 to 10 minutes the growing scotoma size. Sometimes that's over 20 minutes instead of just 10. Migraines with aura. You have the visual symptoms, flickering lights, spots, loss of vision. You can have needles, pins and needles, numbness, speech problems, and other neurological symptoms. Non-pharmacologic treatments, avoidance of the triggers we discussed, regular sleeping habits, and retiring to a dark room and trying to sleep is always one of the best things to do to resolve a migraine. Pharmacologic treatments, you have ergots and triptans, and they affect these neuropeptides from being released and affecting ultimately the vasodilation as well. Ergots are one of the abortive treatments that can be used. CGRP antagonists can also be used. Triptans are the most common abortive treatments, and I don't have time to go into exactly further detail, but we discussed it on the previous slides. Here are some notes in regards to the triptans and the different routes of administration. And here's a step 1 question of the day that goes through a classic migraine presentation and the possible answers. And this is the explanation of the answer and the ones that are incorrect. Okay, so the main takeaway on questions like this, and go through, when we're done, go through the questions, the whole scenario again in your mind, and review the potential answers and the correct one. The main thing is that the examiners that write the questions love to use questions that involve channels and receptors. And so in this case, the patient's presentation of pulsatile unilateral headache consistent with a migraine. Triptans, specifically sumatriptan, are used for first-line abortive, especially if you've already tried NSAIDs and they failed. So sumatriptan is a serotonin 5-HT1B and D agonist. The drug binds to serotonin receptors for the brain, triggering vasoconstriction, inhibition of trigeminal nerve action or activation, and can be administered orally, subcutaneously, intranasally, and reaches peak blood concentration in approximately 15 minutes, faster than any other migraine med. There's the intramuscular injection as well. And they can cause adverse effects like coronary artery vasospasm, mild paresthesias, serotonin syndrome, and therefore they're contraindicated in patients with a history of ischemia, cardiac, cerebrovascular, or peripheral vascular disease, uncontrolled hypertension, and women who are pregnant. And there's all kinds of other things that I would normally go through with you as well about potential clinical implications for other differential diagnoses with migraine symptoms, but that's not what we're doing here today. The major takeaway is triptan, specifically sumatriptan, is first-line abortive treatment for migraine, and over-the-counter NSAIDs had failed initially, and they work through the serotonin receptors in the central nervous system. And that's really about it. Please go back through and look at the diagrams and review the channels. I think that the cartoon illustrations help to simplify this so that it's not as complex as it really is. And sometimes I think it's overcomplicated unnecessarily in terms of clinical practice. But in terms of board questions, I think this will really help you to get a question. If they're asking a simple, fair, straightforward migraine question, this is a great example of that. So I wish you luck, and then if no one has any questions, I will let you refer back to this after we're done. And I recommend to write notes because that's a good way to help improve memory. And then look at the pictures again, because combining writing along with pictorials helps to really improve your memory recall when you're taking exams. And I know for me, there were times during board exams and other types of exams during med school where I would remember specific pages or images because there were diagrams or because I had written out the notes and added some illustrations, because those things help differentiate between just looking at line and line of text after text after text line, which can be difficult to memorize because there's not meaningful correlation in your brain to kind of store the information. So hope all this was helpful, and I appreciate your time. And I hope for you at Kaplan Medical, I look forward to working with you, and I am available immediately. And I would, if you have enough work for me, I will do full-time for you. Right now I have had a slowdown on my other consulting work, so this would be really beneficial for both of us. So I hope that we can move forward together on it, and I really appreciate your time. Thank you very much. Have a good day.